This patient had cataract surgery 1 year ago and presented to the clinic with corneal edema. You could see a little lens fragment inferiorly that was verified with gonioscopy. Because of the decompensation, we decided to take them to the OR. I'm making a paracentesis incision with a 1.2 millimeter blade. Now instilling some BSS to verify the mobility of that fragment. There it is, it's moving around. Now I want to trap it, so I'm going to use a viscoelastic. I learned that I should have used a cohesive viscoelastic. In this case, I used a dispersive viscoelastic. It's just harder to remove it at the end, and both do the job equally well. The other thing I must remember is to not dilate the pupil before surgery, because this fragment can go back and be harder to find. Now making my second paracentesis incision, again 1.2 millimeter, because I want to use a bimanual I&A to get this fragment out. There were two reasons I chose to go with the bimanual. One was that this happened 1 year after the surgery, so the phaco incision has sealed up really well. If it happens on day 1 or day 2 after surgery, then it is easy to open up the main incision. The second thing is, I saw the fragment was tiny and I thought I would be able to use mechanical energy like I am doing right now, bumping the two bimanual irrigation aspiration cannulas into each other to break that nuclear chunk and eat it up. Now just removing the remainder of the viscoelastic, I do a good cleanup. So a couple of things that I learned and I must remember: do not dilate the patient before the surgery. It's easy in a cataract surgery setting for the nurse to dilate everyone as a routine. You have to be very clear in the instructions that please do not dilate this patient. The second thing is not to use lido-phen. Just plain lidocaine will do. If I don't have preservative-free lidocaine, I can just instill BSS because this is a short procedure and topical proparacaine will do. Third thing, use a cohesive viscoelastic instead of a dispersive one. And lastly, bimanual works great in these cases because you don't have to make a large main incision. You can see the cornea is already starting to look happier and less edematous. Just checking my wounds, the patient looked great on post-op day 1. Thank you for watching.